Oh, hey, Chris.
Hey Chuck, how are you?
Good. We're recording at a little bit of a different time.
Yeah, it's actually daylight outside. It's nice, but of course we're both inside and both in the office.
In the office. Yeah, St. Louis weather, I hope is turning for the better. It's we're recording this on the 28th of March, and it's I think the high today was 67, sunny.
No, you're revealing our special secret that sometimes we record the episodes ahead of time.
Oh, should we not?
We shouldn't.
Okay, we'll cut this. I think people know. But anyways, we'll keep going.
Um, so yeah, I think it's been a nice day. I usually get my weather reports from patients in clinic, and when I'm in the OR all day, I actually have no idea what it's like outside, and I sometimes I think it's better if I don't know what the weather's like when I have to be inside.
Oh, for sure. We may have mentioned before at one of our surgical locations we have windows, and for those of you who have the opportunity to operate at a site with windows, I recommend it highly because you kind of do keep a little bit in touch with the outside world. And when I'm in clinic, I just have a big window, and it can be really hard to look outside when it's a beautiful day.
I still remember being at the at that particular site and being in Dr. Gelberman's clinic and just feeling like I needed a refresh sometimes. So I would just watch cars go by the clinic, just thinking to myself to give myself some zen.
Yep. No, it does the trick. It can do the trick for sure. But yeah, the kind of just being in the OR and being oblivious, I guess there's something to that too.
Yeah, there you never know what's gonna what could be unfolding in the world once you emerge from a long case. Like things change. I remember well, I mean, I guess we won't delve too much into the details, but I remember hearing about the details of January 6th unfolding as I was leaving the OR, and I was like, "What just happened in the world?" And
Which
uh, and and then I also remember I was visiting Changgung Hospital in Taiwan as the November 2016 election results were coming in, which was also super interesting.
It's funny. As you started that whole conversation piece, the first thing that came to mind was where was I when? And the immediate one that comes to mind when I was in the OR was September 11th. I was a fellow in Cincinnati, and I was in the OR, and we kind of all walked into the waiting room to watch the television there. A different era, different generation. There was
Right.
one, way to get
One
in.
one
So
TV. If you probably had no remote, you had to get up and change the channel, and
with little rabbit ears. Yeah, yeah, exactly.
Oh man, the other where were you when thing that I for some reason always remember is that the day that Michael Jackson died, I was on call. I was a junior resident on call at one of the hospitals, and I it was just a run of distal radius fractures, patients with distal radius fractures that came in, and I actually had them all kind of set up in an assembly line, like classic resident style, just like ready for reduction. And I'm just going down my assembly line, and patients start talking to each other about how Michael Jackson just died. I always remember that.
That is so interesting. Yeah, I don't know where I was when Michael Jackson died.
All right. Well, we have an interesting episode today. I think we have a case that I wanted to ask you about how you would approach. And then, I think we're going to get into a practice management topic about approach to the workers' compensation program.
Yeah, it's a super interesting. First of all, I think that we briefly discussed the case so we could prepare. The management topic I think will be really fun to discuss. It's certainly something that we both think about a lot, and I think is really important to, future hand surgeons everywhere.
Right, and I think that initially work comp, I think, elicits some kind of like visceral reaction in a lot of people, just groans and oh my gosh, why would I do that, et cetera, so painful. I don't think it's as bad as people make it out to be, but we'll get into those details. Before we talk about our case, why don't we thank our friends over at Practice Link?
Absolutely. The upper link is sponsored by Practice.
The
The
upper
upper
hand or the upper link?
The upper hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/the upper hand.
All right. Tell me about your case.
So I mean, something that comes up, probably a couple of times a year. So, how do you think about patients who, and technically how to approach indications, how to counsel patients who need a ray resection? So I'm not talking about in the context of any sort of oncologic issue. I think that's completely different. But I had a patient who is, an older woman in her 70s who had a very challenging recovery after a complex flexor tendon surgery, and essentially has ended up with a finger that is flexed down, and it's the middle finger, it's flexed down at the PIP joint. The posture is about 40 degrees of flexion. Really does not get any improvement with passive. Has really no tendon glide. Those things we talked about with Macy in one of the prior episodes about tendon gliding. Doesn't have any of that. The MP joint just feels stiff, and her finger is just in the way. And it's not a useful hand. And she has difficulty gripping and grabbing things because she can't initiate flexion with her middle finger. It stays flexed, or it stays flexed, and she can't straighten it out. So she's about a year out from her flexor tendon surgery, and is just not happy. How do you approach that situation?
Yeah, I think that's an interesting lead in to the topic of kind of just challenging finger status. Certainly, there are other potential lead-ins. One would be, bony trauma or partial amputation, something like that. Lots of congenital tie-ins, which I could bore you with for many hours. And, I think when you feel as though you have maximized therapy, when you feel as though your surgical strategies to help the patient improve have reached their limit, then you have to have the difficult discussion about whether that finger can ever be useful for the patient. And it's a discussion that, in my mind, shouldn't be held at one sitting. It's something that you have to plant the seed for and revisit.
Yeah, I think absolutely. I remember you teaching me that. Ryan Calfee is very good at teaching about how to broach this topic with patients. I remember that when I was a fellow, and this patient was not just, and not to, minimize that. It wasn't just a flexor tendon repair. It was much more than that, and involved trauma and pulley issues, and there was not great adherence to post-operative recommendations, both in general and specifically with regards to therapy. So, it's a challenging situation overall. I think, all parties are frustrated. Um, and I, kind of talk through different options. Feel like we had exhausted our non-operative treatments that we had available to us. And I did spell out kind of the things that we would need to do if we were to try to salvage the finger, including, your stiff finger surgeries, followed by to get full passive, and then followed by tenolysis, et cetera, to get some gliding after if you've been able to maintain the passive. So we talked about the multiple steps it would take, and that just, after multiple visits, was not appealing to her.
Right. So it sounds like at this point you're sort of it was the middle finger. I'm not sure if a dominant hand or non-dominant hand, and I don't know that it matters. So your options really are leave it as it is, um, amputate at the level of the MCP joint or somewhere about there, or consider an amputation or with a ray resection plus minus transposition of the index finger. Is that kind of where you were and what you had discussed with the patient?
Yeah, basically that's it. I really honestly did not give much of an option for, an MCP level dysarticulation. And I'd love to know your thoughts as to, whether you think that's a surgery that provides meaningful improvement, or whether you think that that's, is there anything aside from array resection?
Yeah, I think for certain patients, an MCP level amputation is an option. That'll be the patient that just needs to get back to work very quickly and doesn't want to think about extensive rehab and is not overly concerned about that cosmesis and the functional challenges that that gap can create.
Yeah, so tell me about those functional challenges about the gap.
I think the benefit of that surgery is you maintain the width or the breadth of the hand, which has been shown to be correlated with strength. The negative is very simply they failed the M&M test, right? If they're holding a bunch of M&Ms, you're going to lose some through the gap. And I think that is true. We don't worry about pocket change much anymore since none of us have it, but the M&Ms, we still have them.
Right. I'm trying to think of, I think my daughter would love that. She just go and pick up all the M&Ms and eat them anyway. But so yeah, no, I tend to think that that procedure, at least from what I've seen, does not necessarily provide the earlier recovery benefit. And I think the objects slipping out of the hand, the M&M testing, I think that's a real issue. But I think I get what you're saying in terms of the breath. Do you approach this any differently if it's the ring finger?
It no, I don't think so. I mean, certainly so again, as we've discussed, ring finger is going to provide a little more contribution to strength and a little less contribution to fine motor, although I think both can contribute in both directions. But no, I don't think the ring finger fundamentally changes because in my mind, the ideal procedure, no matter if it's middle or ring, is ray resection with a transposition of the adjacent digit. And I'm not sure if you immediately think about the transposition, and we can talk about pros and cons of transposition versus trying to close down the space, but I've been very happy with transposition.
Sure. And before, I think that's would be a great topic to discuss. And before we pivot to that, I mean, how do you approach this if it's an index or a small finger?
Yeah, so and actually, in the last couple of months, I think I've done a couple of each of those. I think they're much more straightforward in the sense that I do a ray resection, and I don't necessarily feel as though I want to take out the entire ray because there's negatives, right? We have tendons inserting onto the base of most of our metacarpals, and I want to maintain those if at all possible. So my goal, if it's an index finger, it's an amputation mid-metacarpal with an oblique cut in the metacarpal. So the obliquity is from distal and ulnar to proximal and radial, and flipped for a small finger amputation. What about you?
Pretty much the same. I like that you're not trying to close a gap or anything like that, and have to worry about transposition. And I think the aesthetics of it are much nicer for the index and for the small. But yeah, no, I think that for me, getting back to this case, I don't necessarily always think about the uh, going to a transposition, because I have found that in my, somewhat limited experience with this, that I have been able to really use those deep transverse intermetacarpal ligaments to close the space in a way where I don't feel like I'm missing a whole lot. I mean, what's been your experience with patients who have had the transposition, those who haven't, and what the classic teachings were?
Yeah, I think you can close the space down. I think it never looks exactly right, but it can look good enough for some people. I have had patients, and I don't do that really anymore. My go-to is a transposition. Um, but I have had people where it stretches out with time. But I think many people will be satisfied with that. And it certainly is a quicker recovery, although I would say not dramatically quicker than the transposition, because you do have to give time for soft tissue healing, which, can be less predictable.
Right, of course. When you do your transposition, how are you, I guess maybe explain what a transposition is for those that may not be familiar with that, and then what's your bony fixation like?
Yeah, and I should preface it by saying the reason I like the procedure is in part because I've done it a lot, because I do it in the congenital population with cleft hand commonly, and in the injured worker, less commonly, but sometimes. And so, essentially, what you're doing, let's use the middle finger as the example. If your middle finger is either absent or traumatized, especially if you have a good third metacarpal, then the goal is to cut your index metacarpal, remove part so cut the second metacarpal, and then cut out the distal part of the third metacarpal, and then you're bringing your entire index ray, you're placing it on the proximal aspect of the cut third metacarpal, and then plate and screws to fixate the finger, and that widens your first web space, which theoretically gives you a functional advantage, or certainly not a disadvantage. You try to preserve the origin of the adductor pollicis. And done correctly, the aesthetics are amazing. Function is great. The hand's a little narrow, but you warn patients about that beforehand.
Right, right. I think those are all really good points in terms of I think the counseling is key about what to expect. Um, how long do you think it takes for that transposition bone work to heal? Standard kind of orthopedic unit of 6 weeks?
I think it's a little longer. I don't know if you've had experience or what your experience. I would say I tell people 8 to 10 weeks. We work on motion right away. That's the other beauty to therapy, very quickly. You have good bony, rigid fixation. I think it just takes a little bit longer. There's a little bit of fiddle factor intraoperatively, and maybe I do more stripping than I would like to admit of the bones, which may delay healing to some degree. But I think it's a little longer than typical, but patients are happy. They're in a removable brace. They're working on motion, and hopefully healing's uneventful.
And how do you orient your bone cuts so that you get to decrease the fiddle factor, or do you cut the bones and then figure it out later?
Um, well, you sort of want enough tension so you're getting kind of automatic compression. Um, and so I sort of either try to cut them at equal levels, that is the index metacarpal and the third and the middle finger metacarpal, or else try to cut the index finger metacarpal a little shorter, so a little bit of a longer residual stump, and then I kind of tilt it in and pop it over before I put my plate on.
Fancy, fancy. And I think for those listening, it's important to note that we are preserving our insertions of our ECRL and B respectively. So our bone work is distal to that on those metacarpals.
Yeah, and this is one again. You do a lot of work that generates high patient satisfaction, and I like to think that I do as well. There's nothing like this when you have a patient with a really difficult problem, typically one that's been a problem for a long time after a trauma. The patient satisfaction for this surgery is amazing, and it takes a very difficult situation and it provides a really good outcome.
Yeah, absolutely. I have a former patient of mine who has had this done, and some pork steaks often show up in the office. I don't know. What's your take on consuming things that patients bring in for you?
I don't hesitate unless it's a weird situation where you're not sure if the patient likes you. No, it's interesting. I occasionally am gifted food. I would say more often it's beverages.
Right. Okay. Well, those are safer, I guess, for sure.
Yeah.
I guess the last thing I want to ask you about the array resection is how do you design your incisions? You have a lot of experience with kind of incision and web space management from your uh, peds and adolescent practice. So how do you design these incisions?
Yeah, it's sort of, I think there's a lot of different ways to do it. What you really have to be careful of is creating the interval between listen, if you're taking out your middle finger, once you excise the middle ray, you have to create a web space between the index and the ring. And so there's different ways to do that. I sort of try to make a racket incision, but I try to do it in a way that I use the web space that exists between the index and middle finger and sort of just shift it over. So you're not sewing in the apex of the web, if that makes sense. You're sort of taking skin, for those on YouTube, you're taking skin um, off the index finger and leaving this whole web space, and then it becomes your new web space between your index and ring finger. So there are good technique descriptions, but I think that's the important part. How you access everything else less important, but it's the web space which is critical.
Yeah, no, I think that's well said. I remember I was telling our resident who was working with me, Dr. Jesse Hu, at the time, that when I was at the VA as a resident, they were getting rid of a bunch of books. And the one book that I took from that was a book called Atlas of Amputations, which has been an incredible book for the rare occasion where you're doing, kind of a more major non-digital amputation all over the body. Just all the incision designs. It was definitely like a wartime book, but very cool, very interesting.
Yeah, another tangent? I'm looking at my bookshelf here in my office. How often do you access books? Real books?
Uh, I earlier on in practice, I would go to books pretty frequently. I actually have two copies of Dr. Gelberman's Nerve Repair Blue Book, which is for anybody listening is a fantastic book that is timeless. 2 volumes. You can oftentimes find it on Amazon. If you find it, get it because it is an awesome resource. But I used to use it pretty frequently, so I actually keep a copy here in this office and one at home because I was able to pick up a couple different copies.
Wow, that's something. Yeah, I still expect if I write a chapter, I want a physical textbook. Doesn't always happen anymore, which is really frustrating to me because the ebooks, I personally, and I know I'm old, ebooks don't resonate with me.
Well, I mean, honestly, if you had the chapter, like, would you actually read the textbook? Because I've got some editions that I've written recently that I don't think I've ever actually opened it, to be honest with you.
No, I don't open it. And I've started to give them away to residents and fellows. No, I still don't open them, but I just want
Right,
it.
if you put in all that volunteer work to do it. I still remember bringing you a copy of my ASSH Elite Athlete book and seriously asking you to sign it during fellowship, and you rejected and just laughed in my face.
I've learned since then. I've grown. I think it was so very briefly, I was recently on a business school trip to DC, and we had a lot of policy experts come to the Brookings Institute and talk to us about different policy things. And there was a really, really good speaker, and I bought his book and asked him to sign it. And he didn't bat an eye. Clearly, he'd done
Right.
this a lot more than I have.
Right, exactly. Yeah, okay, fine. So before we talk about our workers' compensation topic, we should thank Checkpoint.
Uh,
The Upper Hand is sponsored by Checkpoint Surgical, a provider of innovative solutions for peripheral nerve surgery. Checkpoint Surgical is always striving to elevate the clinical practice of peripheral nerve surgery by providing surgeons with new techniques to help improve patient outcomes.
Checkpoint Surgical's newest intraoperative nerve stimulator, the Gemini bipolar nerve stimulator, does just that. With a bipolar stimulation probe, Gemini provides finely controlled stimulation even at the fascicular level, allowing surgeons to take actions based on the most precise information available. To learn more, visit www.checkpointsurgical.com. Checkpoint Surgical, driving innovation in hand surgery. Oh, nerve surgery, driving innovation in nerve surgery, Chris, not hand surgery.
You're fired, Chuck. You're fired.
So,
The purple stimulator is
yeah,
what I also call the the Gemini
oh,
because
that's the
I
bipolar.
can't keep they can't keep it straight between the Guardian and the Gemini, and it was major faux pas on the alliteration in terms of like making them both G's because it's really confusing. But so it just
Well,
ends up being I want the blue one, I want the purple one.
yeah, which is more than I could ask for. Dr. D, you and I are in academic medicine. Do you have any idea what your payer mix is?
I actually do. I can't. I don't know. I know what my collection rate is. I'll tell you that.
Oh,
I actually am not sure.
I'm not
Yeah.
asking for specifics, but in
Right. No, I'm
general.
trying to think like I have a general sense of what my payer mix is because we do get our dashboard every month and I try to look at it. I can tell you what I feel like the biggest ones are and what the smallest ones are. But I mean, did you always keep tabs on that when you were in my stage?
Well, part of the question is simply academic medicine in 2024 is very different at most academic institutions than it was, I don't know, 10, 20, 30 years ago, in the sense that you're not hiding in a very controlled environment. You're not salaried without any knowledge of what's going on. I think most academic practices are like ours, where we are certainly aware of every aspect of the financial part of our practice.
Yeah, no, I think that you could just kind of put your head in the sand and get paid what you get paid. But I do think we're all, at least the people that land here, tend to be of the type where you're pretty type A and you're motivated and you kind of, everybody likes to know what's going on. It's particularly if you're in a position where sometimes, you are incentivized to know what's going on in terms of how you can improve your efficiencies and et cetera.
Yeah, and I may be giving too much credit. I don't think I am, and if listeners, correct me, that would be great. Um, I really think Dr. Gelberman, who was our chair from 1995 to 2014 here at WashU, was really the one who helped to change sort of the orthopedic perspective on what academic practice meant. And it evolved to more like a private practice where we wanted to and needed to know sort of the financial parameters of our practice and didn't just, like I said, bury our head in the sand.
So I mean, I obviously I owe a lot to a Dr. Gelberman and a huge mentor to me. Why do you say that though? I guess you know more about kind of how he came and changed or started things here.
Yeah, my sense is that 30 years ago, there wasn't a lot of attention paid in academic practice about RVUs, about how an academic orthopedic surgeon could generate more revenue. And there really wasn't a sense of kind of shared um, financial benefit in the sense that if I worked harder, I made more money. And the people that Dr. Government attracted here, even back in the day, that model appealed to them. And we kind of developed a practice based around that. Obviously, I didn't know what every other practice, I don't know what every other practice and academic practice was doing, but my sense was he was the kind of really one of the first, if not the first, to really push that model.
Yeah, I think it's people, who either were here and took leadership positions elsewhere or came and kind of understood what he was doing here. There's a lot of things that he initiated here that seem to have permeated to other places in terms of, incentive programs for academic productivity, making sure that that you knew that there were opportunities to earn more if you were more productive. I remember asking him to have an extra research day, which the standard for here was to have one admin slash research day and then four active clinical days. And I told him that I ultimately wanted to have an NIHK award, which meant having 50% research time, for a surgeon. And I said, all right, well, when I start, can I just have two research days? He's like, yeah, you could do it. But he made sure in my agreement it is very clearly stated that it is potentially at the an opportunity cost that my own personal incentive may be compromised if I'm spending all that time on research.
Yeah, that certainly is correct. And I would say that not only so again, if you understand one compensation plan of the many that exist, you understand one compensation plan. And we're not here today to discuss our compensation plan. Again, if listeners are interested, we can certainly dive deeper into this topic. But not only were we incentivized to think about our clinical productivity, we are also sort of responsible for controlling our own expenses. And sometimes practices have part of that equation and not the other. But we had to think about both. And I think maybe that's what made it more unique at the time is that not only should I think about how can I boost revenue, but I also needed to think about how I could control my own cost, who I hire to help me, all those kind of things.
Right. So I mean, to the former about boosting revenue, and I think the intent of your question, I remember I think learning from you that probably work comp is the one thing, accepting work comp is the one thing you can do to really shift your payer mix. I mean, I guess in some systems you could choose whether or not, and then how much to see patients with Medicaid. I personally have an open door for that, but and I know that taking workers' compensation does allow me to at least shift that part of my payer mix in a way that, typically will reimburse at a higher rate than the other payers.
I think that's well said, and that's exactly how I think about it in the sense that I have a large number of pediatric patients, but I don't I have a completely open door policy to any patient without any restrictions whatsoever. That is not universally the case. I'm talking across the country, across different practice types, and for good reason, to be honest. I mean, Medicaid, for example, and it's very state by state, right? States generate their own rates for Medicaid, and so certain states better than others. You will lose money every time you care for a Medicaid patient. Now, as a physician, I still think it's important to care for all those patients, but how do you balance it? I don't think taking commercial insurance balances it. Commercial insurance can typically help pay your bills, but if you really want to sort of balance the low payers, you need the high revenue of work comp, which again, not true for every state, but for many states, it is financially advantageous to care for work comp patients.
Yeah, absolutely. I mean, I think when I was starting out, I still do a fair bit of health disparities research, but my one of the big things I was doing early on was looking at policy changes, such as the Affordable Care Act, or otherwise known as Obamacare, and how that may have shifted, delivery of care. And because Medicaid is a state-based program, and the thrust of the Affordable Care Act was to increase Medicaid enrollment, we were super interested in seeing if, Medicaid expansion plans actually move the needle in terms of increasing the care that was delivered because maybe people were just getting insurance in name. And one of the papers that we wrote was actually looking at variability state by state in what Medicaid will reimburse for certain procedures. And, it was fascinating paper. And it shows it's all over the map and it totally depends. If you're in Alaska, Medicaid's a great payer. But if you're in Missouri, not so much.
Yep, that's exactly right. And so, um, you know, it, again, this is a huge topic. So maybe we'll just and we can revisit it, I think. But if we talk about work comp, for those listeners who aren't familiar with it, so essentially work comp is caring for the injured worker. And every state has its own guidelines about what that means. So I think every state, if a worker has a finger amputation working on a industrial line, that's work comp. But certain states make compensation for repetitive use activities, carpal tunnel. It's very different state by state. We happen to live on the border of Illinois and Missouri, and so the two states are very different in how they think about it. But you have to learn the rules of the game. It's a different kind of patient care than everything else we do.
You know what? I actually want to push back on that a little bit. I think it's not necessarily that different. I think the rules are a little bit different. In terms of actually, most people, I think a lot of people, their first blush when they think about work comp is, it's so painful, it's so much paperwork, it's, I just want to take care of the patient. I feel like, I decided I was going to take it just because honestly, starting in practice, I think you told me I should take it, so I took it, and I was like, all right, I'm going to do this, and now at the end of the day, it does help, support my ability to take care of any patient with a nerve injury regardless of their ability to pay. So that's super important to me. So it keeps, my part of the practice solvent, so that I can, I feel like I can deliver that level of care to whoever needs it for a nerve injury. So you told me to take it, makes sense for me to help with my nerve program. And then I didn't find it to be that painful, to be honest with you. I remember watching you and being in your clinic as a fellow and kind of seeing the steps and getting some advice from you and Ryan Calfee early on about kind of how to handle it. And it's seemed okay so far. We are very fortunate to have an excellent work comp team that helps kind of keep things organized for us. But why do you think it's so different in terms of patient care?
Essentially, well, first of all, I guess I do agree with you. Once you have jumped through the hoops and understand the rules of the game, then you take care of the patient, and that's the goal. But it's the hoops you have to jump through and understanding the rules. And once you have that down, then you just do what you do. And the other thing that's hard, I think, is we as physicians, most of us are not experienced or necessarily comfortable with hard conversations with patients, telling them that you're going back to work. Because if it's a non-work comp patient, it's sort of up to the patient to a certain degree. I don't really push non-work comp patients, and if they have time and are able to take more time off, I don't push them that hard. But for work comp, you have to send them back to work in a with restrictions perhaps, but you send them back to work early as one example of one of the hoops.
Yeah, and I think I'd love your thoughts on this. I'm very clear with patients before surgery. I think this is where expectation setting is super important in the context of work comp, saying most patients after this surgery are back to doing these things by this time. After this surgery, I expect for you to return to work with some restrictions on this date. And as we go every month or 6 weeks, I'm going to relax those restrictions gradually until I feel like you're at the point where you can get back without any restrictions.
Yeah, I think that's exactly how one should do it and almost how one has to do it. It doesn't always mean it's well accepted. And sometimes it's not even the worker, it's the family member, and there's all kind of questions. And that's the other part. You have to be willing to spend more time talking to the patient and the family about what to expect. You often have to talk to a nurse case manager or an insurance adjuster to seek approval or get testing done. Those are just some of the hoops you have to jump through. But in many states, the jumping through the hoops is financially worth it.
Yeah, I think so. And, I think you mentioned the nurse case manager. I don't know how you feel about this. I mean, I feel like, we often talk about how, physical therapists, hand therapists, OTs can be a very valuable, informal source of referrals. I feel like some of the nurse case managers see some of the stuff that we do and how we take care of patients. And I think that helps, build additional referrals to our work comp program. as word gets out of, oh, Dr. Goldfarb can do this, that, and the other, and Dr. D is pretty good at the nerve stuff, that kind of thing. I feel like I've seen some of the same nurse case managers because they've been happy with how, not necessarily they don't know what we do in the OR, but they've seen how people do and also how we handle those situations.
So relationship building is everything in this field, and we probably don't do enough of it. But I can say unequivocally that when a nurse case manager is with a patient in our clinic, it is good for the reasons you stated, right? It can help us build a bigger work comp practice and it helps communicate with the patient. I get frustrated when a patient does not allow the nurse case manager in the room. And that happens sometimes. And that's always under the instruction of attorney who I know means well for their client, but nurse case manager help the process. A good nurse case manager helps the process. And so for me, they are always an asset, but I look at it like that, not as someone that I have to explain things to, but that I do explain things to, and then they can spend additional time if necessary talking to the patient.
Yeah, and I think that once, they're in the room and the points that you need to hit to make sure that they get the information they need. I love it when they're happy that I have addressed, kind of the things they need to write their report. I've said I'm going to do this note for you. We're going to get the therapy prescription for you, and just make sure everything's tidy. And I think, for the people that are listening, and if you're starting out, just know what they expect of you and deliver it. Now, it does end up being a pretty reasonable relationship. I mean, how do you, as we start to wrap up, I mean, how do you talk to new faculty about, whether, to take, to become part of the work comp program, and how it kind of pearls about how to approach organization and that kind of thing?
Um, I think it's really important that a new partner understands what they're getting into. Because for you and I, if someone says, "Yeah, yeah, I want to take work comp," and they do a lousy job, they don't get their notes dictated in a timely fashion, they don't get the patients back to work, they don't communicate well, it actually ends up being a negative for all of us. And so I want to make sure they understand what they're getting into. And it really boils down to communication, verbal communication in the office, understanding of why it matters to get patients back to work, why it matters to close a case as soon as one is able, what it means to watch a patient plateau, and then ultimately say that they're at maximum medical improvement. Other tools we have at our disposal. So it's to everyone's advantage that if we're going to take care of the injured worker, we do it well, because then it's good for our entire practice.
Right. And then I guess there are two things I want to ask you. One, how do you utilize the functional capacity evaluation as patients are kind of wrapping, towards the tail end of their care, but still have some issues, and then you've seen them plateau? Um, and what was that? I can't even remember the last. Oh yeah, ratings. How do you handle the ratings? Because I think that was one thing where I was not like initially enthused about doing, but as I've done more of them, like, oh, this is actually not that huge deal, that big of a deal.
Yeah, ratings are a huge discussion. They're done differently state by state. Some states require you to use the AMA guides and they'll mandate which edition of the American Medical Association guides. I used the AMA guide to kind of give me a general sense when I was starting out. In Missouri, you're not supposed to. Um, and I try to just give an honest assessment because what often happens is I'll give my best honest assessment. And I'm not saying other people aren't answering honestly, but they may get sent by an attorney or by work to a different physician who may lean on the employee side or who may lean on the employer side. And one can see ratings. There are carpal tunnel permanent disability ratings of, 40%. I mean, just
What?
crazy stuff. And so I think our best asset is being sort of the neutral arbitrator who just says what we think as honestly as we possibly can. I think that's appreciated both by the worker, I hope, by work comp, and the next step is the administrative judge, the attorney, the judge who's going to ultimately arbitrate what a settlement looks like.
Right, right. And that's why I think the FCE is helpful, because I think it gives me some numbers and some objectivity, around, to base my final rating on. Um, I think The ultimate test of people's feelings about work comp will be if they've made it to the end of this episode. And when we look at our download stats to see, maybe not put work comp in the title, Chuck. Let's just see if they actually kept listening.
Well, it's funny if when I look at my patient reviews, like when people take the time these days to fill out a Google review, um, I know we've talked about this. I know who all the negative comments are. They're all work comp. I know that, and I know exactly who each patient was and why they were mad at me. But the flip side of that is we don't always see the patients who are appreciative of the care. And, I think most people want to get back to work, want to do it as soon and as safely as they possibly can, which of course is our goal too.
Right, of course. And I guess one thing that's not necessarily just work comp related, but I feel like I need to be better about handing patients the cards that say, please leave an online review, because, it's the happy patients who want to do something to thank you. I still love cookies. I will take them any day of the week, pork steaks, beverages as well. But an online review probably helps more than anything else because there's so much bias with who goes to leave a review.
I need to do more of it as well. I just don't, there's something about me that doesn't feel 100% comfortable with
Yeah,
that
we're
process.
too old school. I'm the same way, but I mean, it's a new generation. You just got to get after it.
It matters, and there's data out there that says it matters. Hey, if you did make it to the end and you want to hear more work comp, well, maybe we'll oblige.
Yeah, good old Goldfarb with all the fan favorites, congenital and work comp. So, all right, have a good one.
All right, you too.